Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your co host, Brian Waterman, a sports and shoulder elbow surgeon at Wake Forest. I'm fortunate to have Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, as my co host. Peter, how you doing tonight?
I'm doing great. I'm really excited to do this with you.
Well, there's no better way that I would like to cap off the evening than a riveting discussion with this crew. But before we get started, I should mention that the views expressed in the podcast don't necessarily reflect the views of the American Shoulder Elbow Surgeons, University of Utah, Wake Forest University, or any of the institutions of our guests. Without further ado, we're going to really talk about a hot and emerging topic in shoulder surgery, which is that of the use of the biceps as an augment in rotator cuff repair. It's certainly become clear that failure of healing of rotator cuff repair is primarily a biological issue. And as a result, there's been several biologic solutions that have been proposed and certainly innovated on. Many surgeons are using allograft and xenograft tissue, but the biceps is locally available. It's frequently discarded at the time of surgery, and ultimately, it's an autograft collagen. So there are several different ways that we're using this, but there's no agreement as to which one is the best one, and there's some potential downsides, and hopefully we can dig into this. So to discuss further, we have invited two international superstars in shoulder surgery. First, I'd like to welcome Jarrett Woodmass to the podcast. Jarrett is a world-renowned shoulder surgeon at Pan Am Clinic in Winnipeg, Canada, where he's been really active in rotator cuff research and does a lot of rotator cuff repair. He also operates within the Canadian health system, and we know that resources are precious. There are some unique constraints, so hopefully he can offer some insights on this low-cost augmentation option. Jarrett, welcome to the podcast.
Thanks so much for having me, Brian. It's an honor to be here, and thank you, Peter, and excited to talk with Eric and the rest of the group. You've been doing a great work with ASES, and I'm looking forward to the discussion.
Yeah, thanks. Thanks for that, Jarrett. And Eric, obviously a man that needs no introduction to the podcast. You're a repeat offender in this regard. Eric Wagner. He's well known to many of our listeners, but for those of you who don't know, he is a shoulder, elbow, and even a hand surgeon down at Emory in Atlanta. He does a large volume of difficult rotator cuff repairs, published a lot on the topic. And I know you to be a really an innovator in this space, and you think deeply about how we repurpose the biceps. Eric, welcome to the podcast.
Thank you, Waterman. Thank you, Chalmers. It's my honor, and I can't wait to get started. This is a really fun topic.
Okay, so preambles aside, Eric, we're going to lead in with you. Let's talk a little bit about the biceps. I want to start with your treatment algorithm and look at where biceps factors into your rotator cuff repair historically. So, what percentage, Eric, of your rotator cuff repairs have typically involved either a tenotomy or tenodesis of the long head of the biceps?
Yeah, I mean, some of my roots trace back to the French. We got to spend some time during my fellowship. Jarrett was one of my co-fellows, so he can attest to this. So I tended to be a biceps killer from the beginning, and truthfully, I vast majority of my rotator cuff repairs and subscap or posterior superior have involved a tenodesis. And then occasionally a tenotomy, depending on the patient, depending on the biceps quality.
What about you, Jarrett?
I've had a
Uniform?
very similar approach. You almost have to convince me to leave the biceps as opposed to taking it. So I historically been a biceps killer prior to, some of this use with SCR.
Okay, so it sounds like both of you were typically addressing the biceps, so we're all kind of on the same page that there's potentially some free collagen here for most of your cuffs. Most cases you were doing a biceps tendon or tenodesis, and there's a couple of different mechanisms whereby the biceps really could help us here. I want to start with the mechanical ones, because these are ones that are easy to understand. I want to start with rerouting. So the biceps normally it goes, through the groove. And the idea of rerouting is you take the biceps, you bring it out of the groove, and you bring it posterolaterally over the head. And this could have kind of both passive and active mechanisms. Actively, the biceps is a better lever arm than to actively depress the head when it comes anteriorly. And then passively, if the biceps is attached to the head, maybe it provides a restraint to superior migration. The same concept kind of as a superior capsular reconstruction. Okay, so we have these two kind of mechanical methods. So I wanted to ask you, Jarrett, like, did this speak to you? Like, when you hear this mechanism, are you doing this in your practice? What are your thoughts?
Well, I've transitioned to doing some of these recently, and I have to admit that it was a little difficult for me to get my head around it initially because it is a non-anatomic change when you're rerouting it and bringing it onto the top. But we use the same structure for multiple things when we're doing SCR. So we're putting if we're using an allograft, we're putting a 3 millimeter graft into a similar location. Now we have a 6 or 7 millimeter graft. We do get that head depression. So like you said about both active and passive benefits, I think it does provide a lot of utility for something that is local and present. And having done a few, I think that the outcomes seem to be reasonable. I think this is going to be a space that gets, bigger and bigger over the next few years.
Woodmass, are you keeping it intact distally, and then second, are you centering it on the head, or are you just kind of bringing it a little bit more posterior? How are you pushing that? You doing Larry Field style, centering and keeping it intact, or are you modifying it slightly?
Yeah, the Larry Field way, basically bringing it to the supraspinatus footprint has been my preference. I've tried both, where I actually did a tenodesis, either subpec or low in the groove, and then kept it and then reattached that segment. And I found that to be a little bit challenging because the fibers in the biceps actually are longitudinal, and the fixation I thought was, reasonable at best. And leaving it intact, I think, has some of those advantages that Peter just talked about. What about yourself?
Yeah, I haven't bought into, I haven't left it intact, even though the data supports to do it, partly because of my concern for just recurrent biceps pain, recurrent cramping, and I realize that hasn't been borne out. I do like to bring it. I don't quite bring it to the center of the tuberosity, but I do think it's worthwhile, like bringing it out of the groove and bringing it over. I usually will actually not leave intact, anchor it into one of my medial row anchors, and then do a arthroscopic tenodesis below the groove. But I do agree with you. It's been super attractive ever since this is sort of caught steam again. I realize this has been around forever, but the ever since Larry Fields really started popularizing this, and your systematic review was a nice one to sort of hit home the point that I think that there's some real benefits with extra collagen, potentially re, potentially reducing the head depression. I think this is something that's it seems here to stay. I don't know, Peter or Brian, are you both doing Larry Fields, or are you all modifying him slightly?
Yeah, it's interesting. I can speak first, and I'm sure Peter has some much more eloquent and thoughtful ways to approach it. But I think when we encounter, and this will segue to our next line of questioning, when we encounter that fairly atrophic tissue in the anterior superior aspect, some of that avascular zone, somebody that has both extrinsic and intrinsic factors working against it, I think it makes sense to make this just a static stabilizer. And even if the tissue's beat up, I've been increasingly incorporating that in and kind of waiting for the other shoe to drop, either in terms of stiffness or soft tissue compromise. But curious, Peter, what are your thoughts as somewhat of a skeptic to new innovations?
Um, well, I love innovation, but I try and think about it. And so maybe that makes me a skeptic. But I want to get. There's a lot to get into here, and we're tiptoeing into some of the other pieces, the biology part. There's a couple, the subacromial thickness part. I want to stick to this concept first of, do we believe that rerouting the biceps has both an active and a passive method to push the head down? And I can believe that. Like I can believe that could work. But I think what Jarrett mentioned at the beginning is really critical. It's extra anatomic. It's non-anatomic to move the biceps out of its groove and put it lateral. And so I worry about that. But I think at the same time, I do think that could work. But again, like, I just think we have to be careful about doing things that are extra anatomic. This is only one of the mechanical concepts, though. Here, there's a kind of second mechanical concept that I think is also very interesting, which is this idea that you can use the biceps as a cable reconstruction. So as we all know, the anterior aspect of the rotator cuff has this superstructure within it called the cable that when it's lost, you unroof the lateral pulley, and then the posterior cuff is at a mechanical disadvantage. So the idea here is the biceps could be sewn to the posterior superior subscapularis and then the leading edge of the rotator cuff that could be then tied to that. And then the cuff doesn't need to be advanced as far anteriorly. It's under less tension. The infraspinalis is then attached to this kind of reconstructed cable. So, I mean, what are your thoughts on this, Eric? I mean, are you ever using the biceps this way in your reconstruction? Because I think this is a distinct concept from the rerouting concept.
Yeah, absolutely. No, and to me, this, I don't know, from an augmentation standpoint, this makes more sense. My problem with the rerouting is I do worry: are you going to put pressure? You know, you're bringing out the groove. You're potentially putting pressure on the where it's like when you reroute it. If you watch it, and I've done this arthroscopically, you can see it kind of like taking a little bit of a turn at as it's passing the pec major. In this case, where you're talking about the anterior cable reconstruction, it's nice because especially if you have compromised tissue, you're not wanting to use maybe a synthetic graft or or an allograft. It is in essence giving you that kind of free graft, free tissue, and allowing your repair, especially that anterior superior aspect of your repair, to have a little bit more biology. So for me, like I hear you on the humeral head dispersion, and maybe I'm thinking about this wrong way, but I actually think the tissue and the augmentation of the tissue, maybe with some minor humeral head augmentation, is the real value here. And I think that's what's caught on. If you look around the world, it's kind of cool. The biceps. One of the cool parts about this podcast I was excited about is if you look at the studies that have emerged in the last 5 years around the world. I mean, you have ones all over Europe and France and Spain and Portugal. You have India. You have multiple Asian countries that are contributing to this. Australia. So there's some really unique ways that people are innovating with this concept. It does seem like this anterior cable augmentation seems to be the one that's catching on throughout, or at least as being published on throughout some of these other countries. So I think while we are the rerouting seems to be the United States or North American approach to it. I do think the anterior cable reconstruction tends to be, or at least in some respects, tends to be around the world. And for me, that's what I usually will use it for, or at least get excited about using it for.
Jarrett, what are your thoughts?
What are your
Anterior cable reconstruction. Is this something that's routinely in your armamentarium, or are you going more routine for the bicep centralization? Can you parse that out?
I agree with Eric's comments. I think it's actually has a great utility for anterior reconstruction. Just circling back to one of the comment earlier that Eric had made about the position, like whether you're doing rerouting as well. I just wanted to point out, if you're keeping the tendon intact and you are doing a rerouting versus a distal biceps tendinous, I think this changes where you're able to put this technically on the greater tuberosity as well. And you probably should be keeping it more anterior if you're doing a rerouting with it intact, as opposed to trying to shift it to the back. I think that the further back you go into the greater tuberosity, the more you affect that, um, the more you affect the tension on the biceps itself. And then for the anterior cable, I have been doing this, but I can't say that I'm doing this on a routine basis at this point. I've probably done you know less than half a dozen cases like that, but certainly intriguing, and probably will be done more in the future.
Yeah, Jared, let's stick with you for a second. When we talk about this, so we talk about it with folks that have been early adopters, Pat Denard, Paul Sethi, some of the others. They've often talked about releasing that lateral sidewall of the biceps groove, which, in some sense can be therapeutic in and of itself. Is there value to that? Is that part of the beneficial aspects of this operation? Or should you leave it intact to your point?
Well, I think that if you're shifting it or rerouting it, I think you should release it. Like, there is synovium that goes down the groove and definitely can be a pain generator. So even when I was doing biceps tenodesis in isolation, I would release the transverse humeral ligament. So for myself personally, I do think it's important to make that release. And then if you're shifting it over, it actually has mobility in and out of the groove if it wants to.
I think that covers a lot of the mechanical concepts, and I wanted to get to the biology. So the biceps contains collagen. There's certainly not just the collagen, but there's also, like living tenocytes in there. And JT Toka has showed us that they can contribute to tendon healing. So here's my question. Like, how much of our effect of the biceps, no matter what you do with it, is just that? And if you use it that way, does it matter how you orient it, right? Do you need the biceps to be oriented in the same direction as the collagen fibers of the cuff? Or does that not matter, and is it just kind of a raw proteinaceous material? What do you think, Eric?
Well, and that goes to also the bicep smash, and some of the other ways
Right.
that you can incorporate this. So, does it matter to have some sort of somewhat anatomic, or does it just matter to actually have living tissue? And I mean, I tend to think with some of the data that's coming out on some of these synthetic graphs that's showing, at least on MRI, that potentially that we're inducing healing responses with non-human, non-autograph non-autograph grafts. I can't help but think, you have autograph tendon, you have autograph, there's multiple studies showing tenocytes, even some progenitor cells throughout the biceps that you're gonna create a response, more robust potentially than some of these even allografts. And so from my perspective, I think that's more important rather than the orientation. I think adding in, it's just like we're doing with bone graft. If we're bone graft and glenoid or whatever else, if you can use your own cells and you can use cells that have been proven to have progenitor cells, I mean, you're already ahead of the game in trying to reproduce this, and especially in some of these poor tuberosities, maybe they they've a little bit more chronic settings. The more biology you can get, the better. I think that's the golden Q, is trying to figure out how do we get some of these, the Q cuffs is a little bit different than some of these subacute/chronic cuffs, and how do we get those to actually heal properly and augment that? I don't know. Woodmass, are you like what's your optimization? Do you think it's do you think this biology? Do you ever use like non-biceps grafts to sort of augment healing when you're worried about the tendon quality or healing potential? Like how are you approaching that?
Well, I've used multiple different graphs to address tendons at risk and try to calculate a Rohe score to see,
Yeah.
which one of these cases are going to be used for that. I think one thing that I just wanted to mention about that biology with the biceps is one of the things that used to always kind of catch my attention was when the biceps had vascular infiltration. You can literally see the vessels floating through the biceps. And I was always worried about that because I think that that's inflammation and that's causing pain. But in this setting where you're actually using it to be now part of your construct, that actually shows that there is in fact vascularity of that tissue. So it makes logically way more sense to me to use that graft as opposed to bringing in a synthetic graft.
Yeah, when are you using this? Are you using Rohe score? Are you to augment? Are you using tendon length or intraoperative assessment? How are you making that decision?
Well, a lot of this is done sort of systematically, similar to what we did in fellowship, but looking at the MRIs critically, looking at the Coutalier score to see how much fatty infiltration there is, looking at the tendon length and looking at the pate grade. So, with those different factors, you can usually determine whether a tendon is going to be reparable or irreparable. And then this is it's, a totally different discussion getting into tendon transfers for some of the massive tears or ER lags. But for me, doing an SCR, whether it's with a dermal patch or a fascia lata or with a biceps, I'm really looking for patients that have irreparable supraspinatus tears with a reasonable quality infraspinatus that I can do an associated partial repair with. What about yourself?
Beautiful. Actually, I'm going to bump this to Peter. Peter, you guys have done some really nice work on grafts and on and inducing healing and seeing the results. How are you approaching this? Is biceps now your go-to? Do you have a role for either structural or regenerative grafts? Like how are you incorporating or deciding between all these different options we have?
Eric, the way that the podcast works is that I'm the host and I ask the questions. And then I don't have to know the answers. Because I don't. I mean, this is part of the reason I want to do this podcast is that I really respect both of you, and I know you guys have both thought about this based on the talks I've seen you, the great talks I've seen you guys give, papers you've written, and I know that you're both really thoughtful, and so I'm hoping, because we've gotten through some of the great things here. We've gotten through, the mechanical advantages, the biologic advantages, and I think there's even some further ones that we can get into. But what we haven't got into is some potential downsides, and I think I want to get into those too to understand them and how they affect kind of your guys' approach. Because what I think is that I have an algorithm that I use, and I'm sure you do too, Eric, and I'm not exactly sure where the biceps fits in it. And I think that's the real challenge that I think a lot of surgeons probably have as they approach, like a massive cuff tear to know, you have the tear, you're like, I know that's the lower trap, and I know that's the, I know that patient is the reverse. I know that patient is, we're going to go for gold, and I'm going to do everything I can to repair them. But where's the biceps within all that? Is it part of every cuff repair? So I don't know that.
Yeah. Yeah, no,
oh,
go ahead, Jared.
Well, I was just going to make one comment and maybe put this out to the group, but two of the big issues that I have with using the biceps, number one is availability. So you have a case that you've planned this for, and I like to have everything planned, set ahead of time, and know exactly what I'm going to be using to a certain extent. Obviously, you can pivot intraoperatively if you need to. But if you get to the case and you plan to do an augment and now the biceps is ruptured, that's sort of a different conversation with the patient, or you have to convert to using a graft. So availability is one major downside that I see. And then the other is the quality of that tendon. So there's mixed sort of literature on this, but patients with slap lesions or significant partial tearing. So I guess I'd propose to the group, are there contraindications that you have based on the quality of the tendon, and what backup grafts do you have available?
Yeah, those are interesting. Those are all interesting points, and I would agree with you. It's sort of it's hard to tell where this fits in, and that's sort of that's what been my curiosity over the last like 2 years, really diving into this, is when to use it, how to fit it with some of the other options you have, structural, non-structural, and I am a fan of augmenting. I do worry occasionally. I do worry if I'm causing stiffness by being too aggressive with some of this augmentation, and probably perhaps seen that, but I can't say I've looked too much into there. But to answer your question, Woodmass, I think for me, I don't worry so much about slap tears, because once again, I'm disconnecting the biceps for the most part. So I'm not as worried about the structure in the superior. I do like it when it's vascular. I agree with you. I think if you look at the biceps by at least up superiorly, a lot of it comes from the superior labrum and kind of comes down the biceps. And so I do think those vascular or those inflamed biceps, probably that's a good sign that you have some biology that's flowing. But when it's really shredded, obviously it's going to be really hard to incorporate into some sort of repair. Or whatnot. And I have not jumped on the bicep smash technique. So from my perspective, that's probably my biggest. If it's not available, or if it's really shredded, I'm not sure the utility. Even if I use it in the bicep smash, I'm not sure the utility of the regenerative capacity of that graft versus using some of the others that I've sort of more routinely used. I don't know. I mean, I have to admit, I've gotten to the point where I've used it almost in any massive, or I guess large posterior superior cuff, and then have used it on every tendon transfer I've been able to use it on. So I've started really jumped off the deep end in some respects, because I do see the benefits. But I'll be curious to look back and see if I'm actually creating a little bit more stiffness. That's probably my biggest concern. I don't know. Have you seen that, Woodmass?
I haven't seen significant stiffness like where someone's getting adhesive capsulitis that doesn't resolve, but I'm pretty certain that I've had patients lose 20 degrees of forward elevation where it's probably just a little bit tight and the head isn't turning the corner quite as easily as it used to, sort of fixed, sort of like the superior capsular reconstruction that we were doing when we were using a dermal allograft.
Yeah, it's fascinating. Do you ever use it for subscap? I think it was India, or I can't remember where it came out of, but a really nice study looking at looking at the use of it to augment your big subscap tears, using the biceps and basically fixing it almost in situ, but using it as really a true cable where they're tying it into the actual upper part of the subscap, and then doing the supra over the top. Have you used it in that respect? Do you think it has a role in that? Are we really kind of over constrain things by using it for the subscap?
I have not done it in that circumstance. The subscap for me, that's a whole other conversation. I try to be very meticulous with my repair of the subscap. I find that once the subscap becomes fatty infiltrated and is a problem, I've had difficulty with any of the different things that I've tried to try to salvage that. But this is one that I have not tried. Have you had success with that?
No, I haven't. I've used it, and I've used it for the super snakes and some combined subscap and super ones. I haven't done it just for isolated subscaps. I was just curious because to me, mechanically, it doesn't quite make as much sense, with the exception of just using as we were kind of talking about from a biologic standpoint. Yeah, I don't know. I mean, Waterman and Chalmers, I know we're not supposed to ask y'all, but like, what are your thoughts on when do you not use it, or when do you what are you worried about with it?
Yeah, Peter, I agree. I think Eric is flipping the script on us a little bit. I'm going to take this the host prerogative a little bit and summarize a little bit of what you've talked about. Sounds like there's not a lot of concern about traction on this biceps labral complex, so maybe we can write that one off. Two, it doesn't sound like there's a lot of concern about adhesive capsulitis. So what are the concerns? And, maybe I'll pose one more. Jarrett, part of the reason why I want your perspectives is I assume there's some sense of cost containment. And I'll tell you, biceps is definitely on the menu when I'm at the surgery center, where they're scrutinizing my overall bottom line in terms of profit margin. So maybe if we can talk a little bit about how cost plays into all this. Let's start with you, Jarrett, and then we'll move to Eric, which are in slightly different settings. I know Dr. Bowden really wants to keep a fairly cost neutral enterprise.
Well,
Jarrett?
there's no question that cost is a major concern for us in Canada. We work under, constrained resources where if we're using it in one place, we have to advocate for those costs to be used, and it has to either come from somewhere else or be, advocated to be in the next budget. So we definitely get monitored for the number of graphs that we're using. I think one of the challenges is that the innovation with graphs is happening faster than the evidence to support those graphs. And so this often gets sort of wrapped into research trials where we'll end up randomizing patients to, the opportunity to have a graft or not have a graft. But the biceps has been, relatively inviting for us because the cost to use, say, a dermal graft or one of the synthetic grafts tends to be substantially larger than the cost of the anchor to reroute the biceps. I'm sure that's similar for some of the outpatient centers in the US as well.
Yeah, the obviously in the US, the ASC is probably the biggest concern because one, potentially surgeons own part of the ASC, or two, obviously that's where some of the cost is scrutinized the most, and you can't get reimbursed for implants as easily. So without question, I think cost is an important consideration. And actually, if you look, I think part of the reason why the biceps augmentation has taken off around the world so fast, or so with so much so much veracity, at least from a research standpoint, when you look at PubMed, I think that's it. I think it's like an affordable way to treat this that's not high cost, and some of these other grafts obviously are much more expensive. And so from my perspective, I do think cost is important. We are lucky enough to have some flexibility in grafts. We can't use any graft in the market, but we have select ones that are on our price plan at sort of the ASC for better or worse. And so we have options of a structural, non-structural graft sort of in each category that our ASC managers sort of negotiate for. And then obviously the biceps. But for me, like I said, I think the biceps has a lot of advantages. I do worry though about stiffness. I haven't seen a lot of stiffness from it, but that's something I'm always sort of concerned about, especially as I'm treating older and older patients and being more aggressive at repairing their cuffs. As it seems like each year I see more and more 70-year-olds wanting to do CrossFit and everything else under the sun. So I do think I do worry a little about this. Jared, you and I have talked about I think you guys were starting a randomized control trial on using the balloon versus repairing and over a certain age. Like, some of these older patients, are you worried about using grafts or repairs? I know, y'all's history of using level 1 data to sort of support a lot of this stuff is great. So I can't imagine that you're not going to eventually give us some answers on this, on when to use grafts from a level 1 standpoint.
Well, we're very fortunate that our patient population for some of these studies is quite agreeable. That partially that has to do with our wait list, but also just culturally. So we've been able to run some of these randomized controlled trials for single versus double row or biceps tenotomy versus tenodesis. I think this is coming, to light as being one of the next hot topics. So something that we're discussing closely amongst our research team. But we really do need level 1 evidence here. I mean, I think that's the bottom line. Is we have multiple small series that are coming out around the world showing that if you do this technique, you have better outcomes than you did preoperatively. Well, most things that we do, at least in the short term, even if you do a debridement, is going to give you better outcomes short term. Some of those are lasting out to 2 years, but I think we need a comparative treatment, which is likely a partial repair, comparing to this intervention to see if in fact we should be doing it on a regular basis, or comparing to the graphs. And just one other comment on that is it's very hard once you start comparing graphs, because this isn't a very large number of patients in that you're randomizing to these things. Like, you have to have fairly tight criteria to make sure that you're comparing apples to apples. So it becomes a very challenging space to do research, because there's many different factors that can end up excluding a patient from being involved in one of these trials.
Yeah, good point.
Jarrett, I think we're really excited for you to publish that research because I guess what I feel like when I hear you guys talk and when we go through it is that there's just a lot of variability in the way people are using the biceps right now. People are rerouting it. People are using it as a superior capsular reconstruction. People are smashing it and using it as an onlay patch. People are using it as what is essentially a longitudinal interpositional patch for cable reconstruction. And each of these are very different from each other. Some people are disconnecting it distally. Some people are disconnecting it proximally. Some people, as they move it laterally, maybe over tensioning it, and that could lead to stiffness or pain. If you don't disconnect it distally, you could have pain fibers running up through from that vascularity you guys mentioned earlier. If you don't disconnect it from the slap region, there are people who think that the biceps anchor could be a source of pain. So there's a lot of plus and minus to each of them. I mean, depending on which technique you use, you may or may not get each of these mechanical advantages, but you may have, each of them has these downsides associated with it. The final one to talk about that we haven't even gotten to is that if the biceps is over the tuberosity, you get more subacromial thickness. That it's kind of like its own little balloon, and it acts like a tuberoplasty. And there's certainly evidence to suggest that tuberoplasty alone may have some advantage. Now, advantage over partial repair, that we don't know. So what I want to ask you, Jared, is when you hear all this variation, like, what do you think is the front runner? Like, when you hear all the different things you could do, like, what's the technique that you like the best currently?
Well, you're right. There's so much variation here. And again, that makes one of the challenges in setting up a study. Like, if you're doing an RCT, this could take, 7 years to complete, to recruit and follow these patients out to 2 years. So you have to be careful. I think you've touched on some very important points. I think one of the biggest ones is that getting coverage over top of the humeral head so that you have that spacer. It's a head depressor. It's about, 6 millimeters in thickness. So, whether you reroute that or if you pull it up or if you disconnect it, I think all of these are accomplishing the same goal of providing a space, uh, filling that tuberosity or that, subacromial space and acting as a head depressor. And I think that if you use that as your general concept, you can probably group a few of those together. But for me right now, rerouting I think makes the most sense. But the space is evolving rapidly.
What about you, Eric? When you hear all the different things you could do with the biceps, but also the potential disadvantages of, like, is it really advantageous to add more tendinopathic tissue to an already tendinopathic cuff? Like, that sounds like it could help, but who knows?
Yeah.
What's your current? Are you using it as a patch? Are you rerouting? What's your current front runner?
Yeah, I mean, so it's interesting because the subacromial space argument, is interesting, and even when we look at our own SCR data, it is true that the ones that were torn off the glenoid still maintained a bit more function than the ones that were torn off the humerus, and so I do believe that that's probably does at least contribute in some respects to it. Even though I'm not somebody who does tuberoplasty, and truly some of the other subacromial spacers have not had great success, and don't sort of not an enthusiast of. So for me, the subacromial space argument doesn't hold up as much because for me that those techniques have not been as promising. But for me, it's about biology. Like if you look at Joanne Addy's original study, when massive rotator cuff fail, they fail within the first 6 months. And I guess in my mind, like that's kind of what I'm going for is I'm trying to give something that's acting as a brace until my partial cuff or full cuff or whatever it is that I'm trying to get to heal back, to try to get it to actually heal, especially kind of reestablishing that force couple, and whatever strategy I'm doing to reestablish that force couple, I'm using the biceps to do that. So for me, it's once again mostly sort of adding biology, reconstructing the anterior cable enough to hopefully allow everything to kind of take over. And I think biology, at least from my perspective, is the biggest advantage, and that's why I'm so enthusiastic about it. And that's why I think I think it will have staying power. I'm not sure which technique's going to win out totally, but I would be curious to see some true comparisons, even if it's just comparing different biceps techniques. Yeah, I don't know. I mean, it's fascinating, but I do think biology is powerful, and I do think that's what I worry about the most with my cuffs is biology. And when I think about grafts, I think about how it'd be great if we had a more biologic cuff that also had some structural stability, and maybe in some respects that's what the biceps is. I'm not sure.
Eric, when you're doing your tendon transfers and you said you use the biceps, how are you
Yeah.
incorporating the biceps into the tendon transfers? And one other comment about the Achilles is it actually acts as a great tuberoplasty or spacer in addition to providing, increased external rotation or restoring that dynamic force couple.
Yeah, I mean Achilles is 12 millimeters. You're talking about tuberosity has a 3 millimeter graft versus Achilles that has like 11, 12 millimeter graft. So you're 100% right there. The and truthfully, Woodmass, when I have had a lower trap fail where it's torn off the greater tuberosity, those patients like have a precipitous decline in function. So I do think that you're right. There is, if it stays in the subacromial space, it has a nice bounce there. And Peter and Bob Tajan showed a nice study on quantifying that from an MRI standpoint. But no, the way I incorporate it is I use the biceps and I incorporate into the first anterior medial anchor, and I will wrap it a couple of times arthroscopically, kind of suture it and crack out a bit arthroscopically, and then I bury that into the anterior superior anchor. So basically, I do a partial cuff repair first. Well, I prepare the biceps SCR or biceps ACR, whatever you want to call it, and then I'll dock it. I'll do the tenodesis, dock it out. Then I do whatever partial cuff, because just as I think you do, I do a partial cuff on every one of my 10 transfers and try to get as much as I can back. And then when I bring the Achilles in, I bury it into the first anchor that I put into the anterior medial anchor. and then sort of finish the rest of it with. I usually do 4 anchors for it, but have you used it at all for lower traps, or are you just doing partial cuffs still?
I haven't, but I think that's a great idea to bring further biology into that area. So I will start doing that. I definitely think that my partial repairs, like when you can do some side to side repair, it's almost like bringing biology to that Achilles tendon. And when you're able to, get a good partial repair and or marginal convergence to that Achilles tendon, I think those patients do the best. So sort of bringing that same concept anteriorly makes sense.
It's like closing. If you look at if you do like a lower trap and then you don't do anything else, there's no partial repair. There's nothing else. You have this big hole, right? And I feel like the more you can fill in that hole, at least the more satisfying it seems. But I do think the more that hole gets filled in, it does seem like the recovery is improved. It does seem like things are better. So from my perspective, it's just like another way to kind of fill in that hole with some biology, with maybe some things to help with the superior force restraint, and once again getting through that first 6 months while the shoulder kind of retrains itself.
So, Eric, one last contentious question. We're moving towards 2026. Rotator cuff tear walks into your office. Who are you leaving the biceps alone? So, benign neglect. What's that patient look like to you?
Yeah, the only person I'm leaving it is the young acute cuff with a pristine biceps that and a pristine sort of transverse scapular ligament. I mean, it's pretty rare. I basically convinced myself almost routinely to not leave it alone. But every once in a while, in a young sort of pristine biceps, I will. But I for the most part, I just I mean, I generally believe the study. There's an old English study looking at the NHS data and talking about of all the shoulder complaints, it was like 40% they traced to some aspect of the biceps. I mean, it's just such a common reason to have pain that I just don't have a lot of hesitation. I joke with my residents, like if we could just release the pec minor in everybody and do biceps, get rid of everybody's biceps, we'd have a lot less shoulder pathology to treat.
That'd be a funny looking gym locker room. Jarrett, what about your thoughts? Is there anybody, you guys I was going to describe you as some recovering biceps killers, but I think you're very much still in this 9-step process. Is there anybody that you're leaving it alone on?
Well, a little bit more and more, actually, I would say that if somebody has a small, full thickness rotator cuff tear where there is a gap between that and the transverse humeral ligament, where I can look at it intraarticularly and the biceps looks normal, the subscap is normal, and there's a little bit of supraspinatus intact before the tear site, I will leave that biceps. And then the second circumstance where I'll leave the biceps is if someone has a high-grade partial thickness tear that I end up completing the tear. And same thing, keeping that the rotator cable and the biceps anchor remains intact.
Well, those
I
are
think this
those
is
are
a great
great
question.
pearls.
Yeah, this is a great question to end on. And the reason it's a great question, I think, to end on is if we think the biceps is so useful, then if we're not using it, should we be throwing it away? Like Paul Sethi said something in a meeting that really got me thinking. He said, I'm using the biceps a lot in my larger tears, and it's made me rethink my smaller tears because if I take the biceps in that tear and then I come back in 10 years, I'm not going to have it anymore if I want to use it in the future. Which, again, maybe it's a little premature to think that, but I think with everything we've talked about, we're all moving towards using it more and more. And it really begs the question, have we done too much in the past as biceps killers? So I love that we've come full circle here, you know what I mean? From the beginning where we said in our training, we learned that the biceps is the problem. And here we get to the end of saying maybe the biceps is something that we should be preserving for the future. This is about all the time we have available this evening for really an ever-evolving topic. We welcome, all the thoughts of the listeners, and hope that this will help them as they kind of unpack their own thoughts on where to use the biceps, what are the pluses and minuses in their own practice. For all of our shoulder level listeners out there, don't forget to subscribe. And for Brian Waterman, I'm Peter Chalmers, and we will see you next time.